This is Module 4.4 of the GO training, Social Mobilization and Community Engagement. By the end of this module, you will be able to describe basic principles of social mobilization and community engagement, even if you're not a social mobilization or community engagement expert. You'll be able to describe how community engagement contributes to stopping the spread of Ebola. And really importantly, you'll be able to identify the linkages between the different thematic areas of work with social mobilization and community engagement, and hopefully link it up to the work that you are being deployed for. A recap of the 4 response pillars: case management, active case finding and contact tracing, safe and dignified burials, social mobilization and community engagement. And social mobilization and community engagement, in fact, contribute to all of the other 3 pillars as well as standing on its own. Communities must be at the heart of response. Ebola happens to communities. People come from families, communities, villages, cities. And without the engagement of communities, Ebola response will be completely ineffective. Quick exercise for you. Take a pencil or pen and write down on a piece of paper why you think we need to engage with communities. Who else has a role in the Ebola response in engaging with communities apart from those people who are designated to do so? So number 1, why do we need to engage with communities in the Ebola response? And who else, apart from the social mobilization community engagement experts, have a role in engaging with communities? Take a minute or 2. So why are we engaging with communities? Everyone has a right to know about the risks to their health and well-being. And engaging with communities allows us to share this information and to discuss it. Culturally, traditionally, socially, ethnically, politically appropriate information can help people who are at risk, in this case of getting Ebola, to take informed decisions to reduce the threats they face. So unless information that we have, the scientific information we have, can be culturally and otherwise appropriately shared and with communities through engagement, not just telling, but through engagement, they will not be able to make informed decisions to reduce the risk to themselves and their loved ones. And actions taken by individuals, families, communities that are affected are key to controlling the public health threat, the problem, and in this case, Ebola. So community engagement is really much more than producing messages, leaflets, posters, t-shirts, radio spots, TV adverts. All of these are channels and tactics and tools to reach communities. But engagement is much, much more than that. What the public hear and what they perceive are 2 different things. This is a very, very important concept in communicating risk before we can understand how we can engage communities. Perception, and that goes for you, it goes for me, it goes for those communities affected by Ebola, are influenced by beliefs, traditions, practices. They can be societal reasons for why people believe something, cultural, religious, political, emotional, traditional. The public have access to information from many, many sources, and their perception is based on these and not just on what officials or experts or emergency response personnel say. So when we go to communities and we hand out a leaflet with key messages, people can be very, very accommodating and polite and nod and listen to what you say. Once you have left, their behaviors could revert back to very high-risk behaviors. And unless we understand there is a step between facts and what we say, and how people perceive these, understand it, internalize it, and act on it, we will not be able to stop the transmission of Ebola and protect people. There's been a lot of studies, and far back as the 70s, Slovik and his team of researchers actually came up with solid social science research that there were some factors that actually affected how people perceive things. So people who are affected by a risk, say for risk of getting Ebola, tend to be more concerned about the health risk if it's involuntary, if it's unfamiliar, if it's controllable or controlled by others, if it's seen as unfair, acute, or it's happening very quickly, or if it's fatal. But these findings also have to be contextualized in the exact analysis of what communities perceive in terms of culturally, religious, tradition, economic, and political. And that's why you will see many response organization inviting and employing anthropologists to try and understand the factors that affect perception. All right, another little break. Pen to paper. Write down who the influencers are of the communities that we are engaging in. So in the context of an Ebola outbreak, reflect on with whom you or your agency will have to engage with in communities. So communities can be many people, from a few dozen to hundreds. So who exactly are you going to engage with? Identify the groups or individuals who are the connectors in the community. There will be people who connect others in the community. What are their power relations with the community? Who are their information sources, preferences? Where do they get their trusted information? So just jot down, if you think you're going to be sent to a community, who you will engage with, and who are the connectors, what are their power relations with the community, and where do they get trusted information? This is something you should do before you start any work on community engagement, regardless of your primary area of response. So here is a graphic that actually maps all of these factors. So again, it's a tool before you engage with communities for you to look at all of these aspects in the context of the community that you are going to engage with. Understanding community practices is absolutely essential. Behaviors and practices before the Ebola outbreak. So how were people greeting? Did they shake hands? Did they hug? Did they touch? How did they care for the sick? Who fed the sick person? Who cleaned the sick person? Did you hug and touch a sick person? It could be the cultural, traditional context in the area you've been deployed is very different from your own cultural context. So please take time to think about that. And you have to think about what were the burial practices before Ebola. Remember, in West Africa, people touch the deceased, clean the deceased. They express and grieve and fall on the body crying. The dead body is not a dead body if it is your family member. It is your loved one who has died. And traditionally, in many parts of the countries that are affected, women come and fall on the body crying as an expression of how they felt about this person and their departure. Understanding community practice, what are we asking them to do or to stop the spread of Ebola? So we're asking people not to shake hands. So this is very different from what happened before. We're asking people not to touch. You will find in many African cultures, people not only shake hands, but they keep holding hands while they talk. And this was before Ebola. So this is a big behavior change. We're asking you and communities to wash your hands frequently, properly for the required amount of time. Remember, not only is it a change behavior, you need the resources. You need water, you need soap, you need clean disposable towels, or you need hand rubs. So not only are the cultural traditional influences, there are practical influences. We're asking people not to do something very fundamental when they see off a person in their family who has died. We're asking them not to touch not only people with Ebola-like symptoms, but not to touch people who have died. We're asking them to take the sick immediately to a treatment facility where no family member may be allowed inside the patient's area. And as I said before, we're asking them not to touch the dead body, which is a very big ask. There are myths and conceptions about Ebola, and there have been many knowledge, attitude, practice surveys called CAP surveys that experts have done. So there was a perception that there was a fear that Ebola equals death, because initially what we knew about Ebola is as many as 90% of people who contract the disease will die. So basically everybody will die, and that Ebola is therefore a curse. There was also dismissal. I don't want to know, I don't want to believe, and I don't want to accept this. There was also disbelief due to distrust. Distrust that authorities can't handle the situation, or that foreigners are here either to bring the disease or to do something harmful, like extract organs for scientific experiments. So in Ebola response, all of these things may still be circulating. And while you are focused as technical, specialized deployees with your specialized knowledge, this is going to undermine what we do. So taking time to understand, appreciate, and find strategies around this is very, very important. So there are ways of decoding some of these things, and this is a map that I'd like you to go through after this module. So for example, if we take right at the bottom of the rumors column, if I just take one example, the rumor was that Ebola treatment centers are killing fields, are killing centers, because the sick go in and dead come out, and we don't really get to see what happens. We have no contact with the patients. We meaning the family. So the underlying meaning is there was incoherence around the issues of treatment and symptoms. The proximity concepts, as experts call them, is that there was boosting the body and mind in traditional healing. So what we need to do is reconceptualize this as building hope, to reframe this as showing the earlier you get treatment in a treatment center, the greater your chance of survival, and therefore this is an act of hope. So we need anthropologists, social science experts, risk communications experts, community, volunteers, survivors of Ebola to all work together in this very complex social dynamic. So I will leave this table, and several other rumors are thought through and analyzed in this way. So let's look back at the Ebola response, the global Ebola response. And remember, UNICEF was the lead agency for social mobilization. And right in phase 1, right at the beginning, we in fact called this social mobilization, where lots of volunteers were trained, went out with key messages, risk messages, preventive methods, and actually did tremendous work outreaching to people. But as the outbreak continued, we realized we had to do more than social mobilization. We had to do community engagement. So in phase 1, it was really social mobilization, crisis communications. And the rationale was past experiences of Ebola outbreaks were associated with 90% deaths. And we knew this because this happened in remote settings. So the key messages was Ebola kills, there is no cure, and that bushmeat, remember, bushmeat was the original route from where this virus came from. Animals, chimps, monkeys, and so on, came to people. And so bushmeat was the spreading of the disease. So this was based on what we knew from previous Ebola outbreaks, which had actually happened in remote areas, remote villages. So this is where we started, and we started with what we had. So there was a lot of massive outreach, mass media, posters, radio, all, if you like, scaring people to do things because Ebola kills. And the outcome was one of denial. And because Ebola had spread before in remote areas and it had initially come from bushmeat, people in other areas thought, well, that's not us. We're not eating bushmeat, so no Ebola risk. And because we had talked about 90% of people dying from Ebola, this was associated, and the no cure was a fact. People understood this as no treatment, and therefore patients stayed at home. Imagine if you are told that you have a fatal illness where it's 90% probability you will die and there's no cure, you might also decide to stay at home, even though you will infect other people. So really it is important to be empathetic, understanding, and really analytical about what happened. Then we moved on to what we call phase 2, and there was a lot more social mobilization, awareness raising as Ebola spread in major cities. But we also saw increased survival rates. Now, so it becomes very difficult to change the messages. So the messages went to Ebola is real, so don't deny Ebola. Here are the signs and symptoms, and do something. Call the hotline. So this became the strategy of that time and the key messages. And the interventions were in campaign mode. Hotline, mass media, print, broadcasts, posters everywhere, radios, town criers, loudspeakers on trucks and motorbikes, road shows, all of these things took place. The outcome was that people started becoming engaged in this, and the demand exceeded the response capacity. So again, this resulted in a lack of confidence, trust in the existing government and other response structures. So you see, if we create demand with engagement, unless we deliver, that can have negative consequences. In phase 3, that is when we really even started changing our thinking and going into a different idea, and we call this community engagement. We saw community engagement as part of the solution and not a tactic. And this was essential to bring back trust. So the key messages at this stage was avoid contact with dead bodies. Remember, 20% of new infections came from contact with dead bodies. The second message, early treatment increases survival rates. And the third is, because people were surviving, we were having problems of stigmatization of Ebola survivors. So we had to have messages and strategies to destigmatize Ebola survivors. And the World Health Organization and many others have actually engaged, hired, employed Ebola survivors to be part of community engagement and to teach clinical care experts about how to treat Ebola patients. So really, we are finding new strategies as the outbreak response continues. The approach here was not one of mass communications, not one of posters and radio and TV. While they were still used, the main strategy and the approach was interpersonal communications. So in community settings, small group discussions, house-to-house visits, community members were engaged and trained in awareness raising and contact tracing. It's important that the key actors in community engagement are from the community. And earlier in this module, we talked about who are these connectors, who are these people, what are their power relations, and how do people get trusted information. So the outcome is that the community influencers are part of the response. Religious, traditional healers, informal leaders, healthcare workers from the community, and many others. So this was a much more decentralized, localized communications, and we could have mop-up campaigns in what were known as hotspots of intense transmission. Give you a couple of examples. And I like to go into this because this is one of my areas of expertise to risk communications. So, how important was this? Here are some news headlines from Reuters, 14th February 2015. Crowds attack Ebola facility, health workers in Guinea. Crowds destroyed an Ebola facility and attacked health workers in central Guinea on rumors that the Red Cross was planning to disinfect a school, a government spokesman said on Saturday. So this is just the first paragraph. This was true. 19th September 2014, deadly attack in Guinea on Ebola team, Al Jazeera. 8 bodies, including 3 journalists, found in remote village following attack on team trying to educate locals. This is a tragedy. Wherever this happens, and whenever this happens to whomever that happens. I know on the 19th of September 2014, I was deployed in Nigeria and I heard about this. And I heard that WHO's team members actually escaped and turned up 2 days later, reporting for duty. Why did this happen? This happened for complex reasons. But this alerts us to spend more time analyzing the social, cultural, traditional context, to have a proper strategy for community entry, to work with community connectors, to have a proper strategy for community engagement and a proper strategy for community exit, and to see community as the center of Ebola response and at the heart of Ebola response in not just the physical sense, but really in every sense that we are struggling with in this response. The second example was the opposite. This is a good example, a positive example of working with community on surveillance in Daru in Sierra Leone, and this was between May, June 2014. This was a really intense area of transmission, but here we were able to empower the community health workers, provide strong political support, engage community right at the beginning, community volunteers trained and supporters, WHO clinicians visiting every day, surveillance teams, contact tracing, really, really working with community. And the result was very, very positive. Monitoring at community and national levels, there's daily reporting, and you will see when you see what needs to be done, how important community engagement is. There is a thing called self-reporting, U-Report, Rapid Pro. So the questions people were asked were, did you see any community meetings about Ebola today? Have you seen any house-to-house visit being conducted today? Did any contact tracers or burial teams report experiencing resistance today? Have you heard of any secret burials this week? Have you heard of any exhuming of bodies this week? Because this happens too. When a burial is done just to keep it safe, sometimes the family go back and exhume the body to do the burial practice in the traditional way and again re-expose themselves. Monitoring at community and national level for this kind of work includes weekly reporting. Again, these questions. Have you heard a rumor relating to Ebola? Did you hear any Ebola messaging delivered by religious leaders at the mosque or on Friday? Did you hear any Ebola messages delivered by religious leaders at the church? Was the paramount chief contacted by any social mobilization partner this week? So here is how at national level, weekly, those managing community engagement kept abreast of how things were going. And also, all of this information would be mapped. So, there was an M-Hero, reports new cases. It broadcasts messages about care and prevention. It allows the sharing of training information. And it allows real-time coordination between the ministry and healthcare workers. You will see in this particular map, which is a decentralized map, you will see the green areas where, say, there isn't resistance, and the red areas was where a resistance to burial is reported. So then we know we need to do much more serious community engagement work in the red areas and to keep the green areas green. Again, at global level, there is monitoring, and you can find reports like this. And really, it is very important to do this data analysis and management so we can decide what actions to take where. Remember, communities are at the heart of Ebola, and therefore they must be at the heart of Ebola response. We have to identify and work with the community influencers. We have to understand community perception, practices, and needs. Our technical knowledge is not enough to deal with Ebola. The power of local leaders, officials, and networks should be understood, and they should be further empowered. We must monitor progress and adapt strategies, tactics, and approaches all the time. All the time. There is no one solution for proper community engagement in Ebola. So, here we are, a quick overview of how social mobilization evolved into community engagement, why this is at the heart of Ebola response, and some of the important aspects of it so that you are aware, you can actually engage intelligently in conversations related to this. But more importantly, I need you now to list how your work relates to or can contribute to the work in social mobilization and community engagement. I also need you to appreciate the complexity of social mobilization. And for the teams that are dedicated to this, it's very important if you, working on case management, on contact tracing or active case finding or safe and dignified burial, can really integrate with this pillar of community engagement. So, your final piece of work for this module is for you to list how your work relates to or can contribute to the work on social mobilization and community engagement. This is the last session of the 4th module. I'll see you in Module 5.